Hi everyone, this is Rihanna and my presentation for you today is on screenings for substance abuse in primary care. So why is this an important topic to me? We all know there's an opioid epidemic going on in America, and I'm sure we've all taken care of patients who have had a substance abuse issue, so we know how common and also how frustrating at times it can be to deal with. And in primary care, they're usually the first ones to see patients that are having pain. Primary care is the go-to before you can see a specialist because half the time patients need a referral, and a fifth of those office visits to family nurse practitioners in primary care are patients presenting with symptoms of pain. Another alarming fact is 26% of primary care patients suffer from a substance abuse disorder, and mortality rates from drug and alcohol-induced deaths have actually increased and surpassed those deaths from cardiovascular disease and cancer. So these are big red flags for pretty much all providers that we need to pay more attention to screening patients to help prevent this epidemic from getting any worse than what it is. For nursing practice and career trajectory, I've had 5 years experience as a nurse in orthopedics and also primary care. I currently work in the hospital now, but I've also worked outpatient before. My goal is to continue working in orthopedic surgery outpatient, but with that or even with primary care, both need to be using the substance abuse screenings. Surgical patients are always in high demand for pain medications due to the nature of their surgery. When I worked at the orthopedic office, it was a lot of spine patients, so pretty much all of them were on pain medications right after surgery. And at the 3-month mark, the surgeon didn't want to prescribe medications anymore, so we'd end up telling them to call their primary care doctor and ask them for pain medications. So we were dumping it on the primary care doctor, so it's important to understand in both fields about the substance abuse screening. I was using the substance abuse monitoring websites multiple times a day to make sure that patients weren't getting any other prescriptions from different doctors around the area. And this can also apply to acute care nurse practitioners as well if they have any patients they feel could be abusing narcotics or alcohol. The most important part is helping out our patients and making sure we're identifying if they have a problem, and with screenings that can be done pretty efficiently. The American Medical Association recommends screening patients as a vital first step and urge clinicians to do so routinely. So that means at their first appointment with you and then for any follow-up appointments. So patients also have an increased risk of other mental health disorders when abusing substances such as major depressive disorder and generalized anxiety disorders. So with primary care, prevention is always key, and it should be utilized as much as possible to help our patients out and make sure we're giving them the best care that we can. And also for family nurse practitioners, one of the largest groups of providers treating patients suffering from chronic non-malignant pain. This is just a list of the different screenings we're going to be going over in the next few slides to come. First is New Jersey Prescription Monitoring Program, and then Pennsylvania has one as well. The SBIRT, I'll go over a little later what those letters stand for. The CAGE-AID, the ASSIST, the SOAP-R, the Opioid Risk Tool, and the urine drug screen tests. So first up, for the New Jersey Prescription Monitoring Program, pretty much every state has their own monitoring system for opioid prescriptions. It's pretty straightforward. Access is granted to the prescribers, and they can also delegate that to anyone who has a license that's within good standing. If you're a prescriber, all you need to do to sign up is have your email, your MPI and DEA number, your date of birth, and full name. And then if you're a delegate, what will happen is they'll email the main prescriber an email just to confirm that they want you to be able to have access to the website. So when you go on, you can just type in the patient's name and date of birth, and then it'll pull up what controlled substance was prescribed, any of them really. If they have multiple ones, they'll show up. Their prescriber who has prescribed it, and the pharmacy it was filled at, and I think it also shows you the number of tablets that the patient got for the medication. So if they got 75 tablets, that'll show up as well. So it's a really great tool to use to see when actually they got it filled. So I'm sorry, it will also show you the date of when the prescription was filled. So if someone calls you, say today, and they're like, oh, I need a refill of my oxycodone, you go online and you see that they got another prescription filled by a different provider 3 days ago and they got 90 pills, you obviously know that they don't need any more of that oxycodone. For Pennsylvania prescription drug monitoring program, this is pretty much just the same as the New Jersey one, just it'll look at pharmacies in Pennsylvania. So it's integrated into all electronic health records and pharmacy management systems. It qualifies also for meaningful use for incentive payments from the state, which is nice. You can get a payment back if you're using it. So the same thing, you can see exactly what controlled substances were prescribed, the prescriber, the pharmacy it was filled at, as well as the date it was filled and how many of the medication they're getting. Both of these are good because a lot of people in this area either live in Pennsylvania and they come to New Jersey, or the opposite. You could be working in Pennsylvania and they live in New Jersey. So it's always nice to check both. When I worked at the office, I was always checking both just to make sure, because you're not sure sometimes if they're getting it filled at a pharmacy near them or if it's near the office. So it's always good just to be safe. The next is the SBIRT. It stands for Screening, Brief Intervention, and Referral to Treatment. So this model has been taught in nursing master programs as an evidence-based process design. So there's 3 main steps. First is to screen individuals at risk for substance abuse disorders. The next is to implement a brief intervention such as a negotiated interview. And the third is to refer to higher levels of treatment to maximize opportunities. So it helps identify someone needing help. The intervention can be done quickly to make the patient aware of their substance abuse, and then they can be referred out if needed to a higher level of treatment. For the CAGE aid, so this stands for these questions right here. These are questions you ask in the interview. It's really quick. It only takes less than 4 minutes to complete, and this one can be done in person or on paper and pencil. So the first question to ask the patient is, have they tried to cut down on drinking or drug use before? The second question is, have they ever felt annoyed or angered by others complaining about their drug or alcohol use? Have they ever felt guilty about consequences of drinking or drug use? Have they ever needed drinks or drugs in the morning to decrease their withdrawal effects? So the higher the score, the higher the need for further questioning. So for 1 point for women, that's a concern. And if they're men or also women, 2 or more points, you're going to need further assessment to help figure out how much of a substance abuse issue there really is going on. But this is great if you just need a quick screen and then you can move on from there. The next one is called ASSIST. It's the Alcohol, Smoking, and Substance Involvement Screening Test. So this one's good for adolescents between 12 and 17 because all the other ones are mainly geared towards adults. So this has 9 categories of psychoactive substances with 8 items for each. It looks at lifetime use or a past 3-month history. And again, they're categorized into low, moderate, or high risk categories. This one can take a little longer to administer because there is 9 separate categories, but for adolescents, it's great since this is pretty much the only screening tool that can be used for them. Next, it's the SOAP. It's called the Screener and Opioid Assessment for Patients with Pain Revised. This revised one has 24 questions. It has a screening with a scale goes from never to very often. There is a shorter version that's 12 questions, and that one's nice, again, if you need a quick screen, because usually with the short one, if they answer yes to 6, to pretty much half the questions, then you know that you need to move on to a more detailed assessment. And some of the questions they ask are about feeling impatient when at the doctor's office, if there's tension at home, cravings for medication, and borrowing pain medication from family or friends. This is the opioid risk tool. So this is what it would look like if a patient was filling it out on paper. It was developed in a chronic pain population and can be used for primary care or even oncology patients. So there's 3 categories again. Low risk is 3 or less points. Moderate risk is 4 to 6 points. And high risk is 7 or more points. So as you can see, if you have any family history of obviously a prescription drug abuse, you're 4 points, you're already at moderate risk. So with this, if they say yes to any of these, really, you're already at risk for a substance abuse issue. The last one we're going to talk about is urine drug screening. So this helps identify drug use and when patients are using any other types of medication to control their pain. Again, there's 3 categories. There's the low risk patient, which means that they're compliant with medication and no history of mental health issues or abuse. So this means for low risk that they would need a drug screen as needed. For a medium risk patient, they're going to need a drug screen at least once yearly. That means they have a history of mental health and abuse problems. And high risk means that they're going to need a drug screen a lot more than once yearly. The high risk group is they're less than 25 years old, they have multiple mental health issues, and they have repeated issues with narcotics, and they're taking methadone. The only issue with this is patients can refuse to urinate in the cups, and then that can kind of limit you with this type of test. For a conceptual framework that really helped guide me through this project, it was Bandura's social cognitive theory. So this theory looks at self-efficacy and the relationship between environmental and personal and individual behavior. So with addiction, it's known as a behavioral disorder, and a lot of the times it's combined with environmental factors and personal factors that put the patient more at risk for having abuse. So with this, using a non-pharmaceutical intervention with these screenings, it also helps teach patients about problem-solving skills, and involves self-projection about maybe why they're using the substances, and social support like providers can be very helpful and benefit the patients to hopefully get them away from continuing to or starting to abuse the substances. For future research, so one study that I would be really interested to see would be genetic testing from buccal swabs to look at if there's any type of genotypes that would play a factor in patients abusing substances. So one study had showed the significant role that genetics play in risk for opioid abuse, but this isn't really used anywhere that I know of to look at the risk. So the goal would be, again, to measure genotypes combined with their personal history to see if it makes a patient too great a risk of trying an opioid regimen. So if you were too great a risk, this would totally not, it would make sure that you weren't giving any type of substances that could cause addiction. And then for qualitative research, I think it would be interesting to see a patient preference on completing these screening tools on paper versus the computer. So a lot of the ones I researched, they were either face-to-face with the physician or on a piece of paper that they could fill out in the office. But there wasn't a lot of information on actually filling them out on the computer, and I feel like in today's world, everything is done on the computer. When you walk into the appointments, half the time you have to fill out pre-appointment paperwork on an iPad now. So it'd be interesting to see what patients preferred, and if they could fill it out on the iPad with the pre-appointment questions, if they would feel more comfortable doing that. That way they're not right in front of the provider. It's maybe it wouldn't make them feel as anxious answering questions. If for people that have like white coat syndrome that get super nervous around providers, it would just maybe make them more at ease to be telling the truth with their answers. And overall, so the goal for this whole entire presentation is just to keep educating other nurse practitioners and students on the importance in different ways to screen for substance abuse. So with this, I just want to make sure everyone knows the different ways. They can even pass it on to their coworkers and maybe even use it in their current jobs right now, but just to make sure we're doing what we can to screen patients and help prevent the opioid epidemic from getting any worse. These are my references, and thank you so much for watching.